Morning, everyone. I think that is everybody in from the waiting room. Thank you very much for joining us early this morning for an update for clinicians who are providing care and support in aged care facilities across the ACT. My name's Sally Singleton. I'm one of the public health physicians with ACT Health. And I would like to start by acknowledging the traditional custodians of the lands from which we're all joining this meeting today, noting that most of us will be joining from the lands of the Ngunnawal people. And I wish to acknowledge and respect their continuing culture and the contribution that they make to the life of the cities and regions that we're all joining from today. And also acknowledge and welcome any other Aboriginal and Torres Strait Islander people attending the meeting with us today. So we're going to work through, so we've got 3 presentations. The first will be an update on COVID-19 care for people residing in aged care facilities from Dr. Marianne Cool. We'll then hear from Dr. Anne-Marie Svoboda on experience with prescribing COVID-19 antivirals in aged care facilities and some of the tips and tricks to consider. And then a public health update from Drs. Gaj Perry and Emily Humphreys, including some information on some antiviral pre-assessment resources that will also be available for people if they would like to use them in the ACT. So I'm really conscious of time, so I think I'll hand straight over to Marianne Cool. Oh, and sorry, I should say that if people have any questions, if you can use the Q&A tab, which is down in the bottom right-hand bit of your screen, you'll see 3 little dots. If you click on that, you'll see a Q&A option. If you've got any questions, very happy for you to post them in there, and we should have time at the end for some facilitated questions and answers. Anything that we don't get time to go through, we'll take a note of and endeavour to get back to you after the meeting. So without any further ado, I might hand over to you, Marianne.
Okay, so hopefully a lot of the questions you have will be answered at the end. And I'm just going to share my screen. Okay, so last time I did this was in January, and fortunately not too much has changed since then in terms of treatment. So in terms of the assessment of the COVID-19 patient in residential care, there are just some key things that should be noted. Obviously symptoms, the type of symptoms that a resident has, but importantly, onset of symptoms, and that's mainly so that we are aware when, because of antivirals being available and the need for antivirals to be commenced within 5 days of symptom onset, it's usually a good idea to note that, regardless of when the test became positive. Risk factors for severe disease are worth noting, but now that we know that antivirals are basically indicated for everyone in residential aged care, it's not as important. Medications have become much more important to note, really because of the interactions between ritonavir, which is one of the active components of Paxlovid, and various medications. COVID vaccination status is still important because it does assist in working out algorithms for treatment, but not so much in the residential aged care setting. This is, I think, more important when we're talking about hospital treatments. You're all aware about the importance of next of kin and identifying the EPOA and goals of care as well. In terms of physical examination, really, I think if we took 2 things from this sort of slide, it'd be checking a person's oxygen saturations and their temperature. So really, the other things are not as important, and certainly chest auscultation is not being obviously done as frequently. I know that people like Paresh have been able to do some of these things remotely using remote technology, which is great. But in the end, I think we can identify a patient as being sick just by standing next to them and seeing their saturations and respiratory rate. we do know that you can get a degree of decompensated heart failure during COVID. So some sort of assessment of fluid status through blood pressure and heart rate check and looking at their work of breathing is useful. And finally, what we're finding a lot is that delirium is very much a component of COVID infection, and delirium can be one reason that a person deteriorates or doesn't drink enough. So some sort of delirium assessment is a good idea. The one that I tend to use is called the 4AT, and I can distribute that later if people wish to have a copy of it. What happens once a person is, once a resident is diagnosed with COVID? Generally, a daily review should consist of checking for symptoms, any new symptoms, a little bit on their exercise tolerance. It is important to try and keep the person walking, obviously within their room or within the area as much as possible, as long as the room facilitates that. I think there's two people waiting in the lobby. If Kunal, if you could let them in, by the way, in terms oxygen saturations. Generally, the rule is no different from other types of respiratory illnesses. We aim for oxygen saturations of more than 92%. And if there's a chronic underlying lung condition like COPD, more than 88% is acceptable. We could take temperatures, but I think generally they don't have a bearing so much on algorithms for treatment. Making sure someone's eating and drinking enough and mental state. So those would be the sort of 5 or 6 clinical parameters that we would review each day. So the next section is a discussion really on what's mild versus moderate versus severe illness. So mild and moderate illness are what you will be seeing in residential aged care and treating, whereas severe illness would be somebody, if they wish to, would be transferred to hospital, or a hospital in the home would be involved in management. I think that's, sorry, there's been a bit of an error there. So basically, in terms of mild illness, it's basically people who have no features of moderate or severe disease. In other words, they only have mild symptoms and signs. There's no new shortness of breath or difficulty with breathing. And there's no evidence of a lower respiratory tract infection, either on chest auscultation or very, very rarely in a nursing home environment on an imaging. So these people with mild disease is, I think, the majority of residents who get COVID. For moderate illness, this is a stable patient with evidence of lower respiratory tract disease. So this might be indicated either by low oxygen saturations, so 92% or lower, and desaturation on breath or breathlessness with mild exertion, or on imaging. So anyone who's getting some more significant respiratory symptoms, we would say has moderate illness. And severe illness, and this is worth noting in case somebody with a mild illness then becomes more severe and may warrant escalation of care, is somebody who's got moderate disease but is deteriorating, or a patient meeting any of the other following criteria. So respiratory rate more than or equal to 30, oxygen saturations have now dropped to less than 92%, or there's lung infiltrates. Now, lung infiltrates we would really rarely see. So it's really the respiratory rate and oxygen saturations that will help us determine that a person's getting more severe illness. Just for your information, and more, I guess, to think about palliative care, is that critical illness is when you have evidence of organ failure, either respiratory failure, so the person's, respiratory saturations aren't responding to oxygen, when they have really low blood pressure or shock, or impairment of consciousness. And often all three of these can come on quite suddenly in someone with severe illness. What do we do then when somebody is deteriorating? So it's important earlier on that we have got discussion of goals of care. This should be a collaborative agreement. Obviously, I think I don't need to teach you all how to do this because you've been doing it day to day in the last months and years. And if you're unsure about recommendations for goals of care, or you would like assistance with a particularly difficult situation where there's a bit of conflict with what the resident wants or family want versus other care providers, I'm available, and there's a geriatrician on call available through Canberra Hospital as well. We also have palliative care physicians through home-based palliative care and the PEACE team for further advice. What does the goals of care look like? I guess in general, they do look different in every setting, but in general, A is someone for cardiopulmonary resuscitation and for hospitalisation if necessary, and then all the other treatments attached with that. B is not for CPR, but hospitalisation if necessary and potential candidate for a higher level of respiratory support, but maybe not for intubation or things like that. So they might be accepting of high flow oxygen or non-invasive ventilation. C might be somebody who's not for CPR, but for active management. And then D would be someone in the terminal phase of illness. So it's useful to think of this in the four sort of categories. Remember that frailty is important in determining treatment, but really most of our residential aged care patients will have high clinical frailty scales, but frailty does determine mortality. What happens in terms of management? So in terms of the different disease categories, so for someone with mild illness, we're really going to commence antiviral therapy. Anne-Marie will talk about this in more detail. Budesonide inhaled if the person's able to do this. We generally don't start dexamethasone, and just make sure that if there's not enough fluid intake, consideration of some subcutaneous fluids like a litre over 12 to 24 hours subcutaneous may be worth thinking of. And you might consider oral antibiotics if there's evidence of a mild community-acquired pneumonia suspected. I'll skip over this, but this was about risk factors for disease progression, and basically anyone in residential care is a risk in itself. There are definitions of what an immunocompromised patient as well that can be looked up through mainly the ATAGI website, ATAGI, but we won't go into this in more detail. In terms of management of more moderate to severe illness, this is when a person's now requiring some oxygen. So dexamethasone at this stage is indicated rather than budesonide inhaled. And if someone's not able to take dexamethasone orally, it can be given subcutaneously. Consider some anticoagulation, DVT prophylaxis, either with enoxaparin or Clexane. And then at this stage, you might consider antibiotics if there's some sign of community-acquired pneumonia. These are the antibiotic guidelines for community-acquired pneumonia. So generally, amoxicillin is a preferred medication, or doxycycline if there's a penicillin allergy. Overall, the best, if you're like me and have trouble remembering things, the best thing to do is download this National COVID-19 Clinical Evidence Task Force guideline. I'll leave it up there so that you can use your phones to QR code scan the little thing on the corner here. But it's worth printing this out and sticking it around the place, on the back of the toilet doors or whatever. But often it's very difficult in the heat of the moment to remember all of those recommendations. You might want to know when to do blood tests. It might be useful for monitoring response to oral or IV therapy if pneumonia is suspected. But I know that it's very difficult to get pathology done and other things during an outbreak. So this is not necessary, and clinical parameters may be enough to determine if someone's responding to treatment. It may be useful to do blood tests if you're thinking someone's very dehydrated, so checking their kidney function. And generally, imaging is not necessary. If someone's needing imaging, they're needing to go to hospital. So I'll leave it at that.
Thanks very much, Marianne. Appreciate it. I might, there are a few questions in the Q&A, but I might suggest that we move on to Anne-Marie's presentation, and then we'll come back to the questions at the end, if that's okay.
Okay. So my name's Anne-Marie Swoboda. I'm the Medical Director of the GP Liaison Unit at Canberra Health Services. I'm also a member of CHEC, which is the emergency COVID emergency, oh God, I should remember what it is, Hospital Emergency Control Centre. And I'm a GP in private practice at Fisher Family Practice. And at our practice, we have about 30 people who we look after who are in residential aged care, mainly on the south side of Canberra. So we've had some experience with managing COVID positive patients in outbreaks. So I was going to talk a little bit about the antiviral medications today and how we use them and how they work. So this first slide is it's just a little explanation of how the antivirals work. And this is how I like to explain it to people. So when a virus enters your body, it invades the cells of your body, and that virus starts to replicate in the body. And it has a couple of different ways that it replicates in the cells. And the medications that we have to treat COVID, the two antiviral medications, block the replication of that virus within the system. So by doing that, we're making sure that the amount of virus in the body is not as high and doesn't overwhelm the immune system, which is where people run into trouble with more severe and serious COVID disease. So if we keep the viral load low, the immune system can cope, and that person is likely to keep their mild infection and overcome the mild infection. So if we look at who's eligible for antiviral medication, the first thing is that we need to be sure that they have a positive diagnosis for COVID. So we confirm that either with a PCR or with a rapid antigen test. And so long as that rapid antigen test has been registered with ACT Health, then that person is eligible for antiviral medication. They also have to have signs or symptoms of COVID infection, and it has to be within the first 5 days of symptom onset to be able to be eligible for medication. So there's no evidence of any benefit of medication beyond that 5 days. And they shouldn't be requiring oxygen to be eligible for antiviral. Of course, some of our residential aged care facility residents are already on baseline oxygen. So long as we know that they've what their baseline saturations are, we can still prescribe the antiviral medication if they're suitable for it. Phew, thought the slide wasn't going to work. So the next slide is just about who is eligible, so PBS eligible for antiviral medication. And the most important thing to know is that all our residents in residential aged care are eligible. So if you live in a facility, an aged care or a disability facility, you're eligible. And it doesn't matter what other medical conditions you have. You don't have to have diabetes or kidney failure or any other condition to be eligible. So Marianne already mentioned the living guidelines. This is where the evidence is for why we recommend the antiviral medications. And Marianne already provided the link, so I won't go too much into this. But Paxlovid is the first medication. So that's a medication that has two different drugs in it, which I can never say, ritonavir and Molnupiravir. I can never get that right. Anyway, that medication is used. It's twice a day dosing. It's for 5 days. Paxlovid is the preferred medication in that it does have the best evidence for preventing more serious disease and preventing hospitalisation and death. The second medication that's available on the PBS is a medication called Legebrio, which is Molnupiravir. So it's our second line medication. Again, it's a 5-day course of antiviral medication at 800 milligrams twice a day. It's 4 capsules twice a day, which is something that we need to consider with some of our residents who may have very high medication or tablet burden and may have difficulty with swallowing. So if we look at Paxlovid and some of the issues around Paxlovid, one of the things we need to be careful about is the renal function of the patient. So if somebody has poor renal function where their GFR is less than 30, then Paxlovid is contraindicated. That's going to apply to many of our facilities. If they have renal impairment where their GFR is between 30 and 60, then they can still have Paxlovid, but they have to have a renal adjusted dose. So it's a reduced dose of medication. The other issue with Paxlovid is that it has a lot of interactions, and that's because of the pathway that it uses in the body to metabolize the drug, which can cause interactions with other drugs. So there's a Liverpool interaction checker where the prescriber can check to make sure that there's no serious interactions with their usual medications of the resident. And it's really important that this is always checked if you're going to use Paxlovid. So with Legebrio or Molnupiravir, it's safer to use in that we don't have to consider renal impairment at all, and there's no dose adjustment required for people with reduced renal function. The dose, as I said, is 800 milligrams twice a day, so that's 4 capsules twice a day. There's no interactions with other medications to consider, but we do have to consider the tablet burden and the ability for somebody to swallow the medication. There is, I'm sure you all know, there's the don't rush to crush guidelines. And so for people who do have swallowing difficulties, we can still use these medications, but we just need to consider it very carefully about the individual risk. And as Marianne indicated in her talk, if somebody is eligible for antivirals, then it's always worth considering starting Pulmicort or budesonide turbihaler at the same time. That's if they have the ability to manage the device. So I was just going to finish up with a couple of case studies just to highlight some of the issues around prescribing. And these case studies come from patients that I have in facilities. So Grace is 95 and she has a positive RAT. She's got 2 days of symptoms with runny nose, cough, and she's a bit sleepy and just not eating and drinking as much as usual. Her examination is temperature of 36, so she's got normal temperature, her respiratory rate's okay, her oxygen saturations are fine, but she's a little bit tachycardic and her blood pressure is 110 on 70. Importantly, she's had 4 doses of vaccine, so she's well protected for her COVID infection, and she's only got mild symptoms at the moment. But she's on lots of medications. So she's on Aricept for her dementia, she's on digoxin for her atrial fibrillation, and she's on apixaban for her atrial fibrillation as well, and Ramipril, Lasix, Fosamax, Panadol, calcium, vitamin D, and Movicol. So she's very typical of some of my patients. And her most recent kidney function test was done in 2020, so it's a little bit old. And her kidney function was already impaired at that point with a GFR of 40. So when I check with her medications on the interaction checker, I can already see that I have 2 significant interactions with Paxlovid. So apixaban is, and Paxlovid is contraindicated to go together, and also digoxin is a problem as well. So if we give Paxlovid with this particular regime, she's going to potentially run into trouble with digoxin toxicity and being over anticoagulated. So for this particular resident, the most appropriate antiviral would be to give her Molnupiravir. So she's able to swallow that, and she's prescribed Molnupiravir. The second case is Bob, who's 85, and again, he's positive on a RAT test, similar symptoms with just 2 days of symptoms, but also reduced oral intake, reduced fluid intake. He's got a low-grade temperature, normal oxygen sats, and normal pulse and blood pressure. And he's also had 4 doses of vaccine, so well protected. So his medications, he's on Lipitor, so a statin. He's on metoprolol, he's on Panadol, he's on some aspirin, and he's on Cipramil as an antidepressant. And again, his kidney function, last kidney function test was done 3 years ago in 2019 with his GFR a little bit impaired, it's sitting at 60. So checking him on the interaction checker, again, there's an interaction with Lipitor, but otherwise there's no significant interactions there, and we could prescribe him Paxlovid. However, because his kidney function was done a couple of years ago, it's really not safe to prescribe him Paxlovid. So once again, the decision's made to prescribe Molnupiravir in this particular case. And then the last case is a 79-year-old lady, Chris, who's also RAT positive, very similar symptoms to the other residents, but on examination, she does have a temperature of 38. Her oxygen sats are a little bit down at 92. And unfortunately, she's only had 3 doses of vaccine, with her last dose having been November last year, because she happened to be in hospital when the 4th dose was being given to the residents and missed out. Her medications are a statin. She's also on digoxin for her atrial fibrillation, some Panadol, an antidepressant, sleeping tablet. She's on some opiates. She's on gabapentin, allopurinol, metformin, amlodipine, and some Symbicort. But she has got a recent kidney function test from when she was in hospital in June with a GFR of 45. So again, checking the interaction checker with her, there's an interaction with Lipitor, but we could stop her Lipitor. We also need to consider the Targen in this situation as well. So with Paxlovid, if we give Paxlovid with Targen, then her opiate dose might be increased, and that might cause more issues with respiratory suppression and sedation. So we need to think about that very carefully. Might need to reduce her dose of opiates. And she's also on amlodipine, so which can have a mild interaction with Paxlovid, but it's probably worthwhile considering giving her a renal reduced dose of Paxlovid in this situation, because she's under-vaccinated and she has more significant illness. So that's a conversation that would probably have to have with the family about whether or not to risk the Paxlovid or give her Molnupiravir. And on balance, probably she should have Paxlovid if it's possible. And that was the end of my presentation.
Thanks very much, Anne-Marie. I might move on to the public health update. So Emily and Gaj, I think if you want to share the presentation, and then we will definitely have time to work through some of the questions that are in the Q&A box.
All right. Good morning, everyone. My name's Emily Humphreys. I'm one of the members of the ACT Health Medical Officer team, and I'm going to chat to you really briefly about an audit we did on Molnupiravir use in residential aged care facilities. And then I'll hand over to my colleague, Gaj, who will chat to you about pre-assessment. All right, so just a quick background. So Molnupiravir was approved by the TGA on the 18th of January this year and was put on the PBS and pre-placed in residential aged care facilities on the 1st of March. We'd received mixed feedback, I guess anecdotally, on usage from facilities and clinicians. And really it was recommended for unvaccinated people, immunosuppressed, and people who were ineligible for other antivirals. We did this audit because we really wanted to get an understanding of what the uptake of Molnupiravir was actually like in aged care facilities, but also get an understanding of the barriers to use so we could better support clinicians and aged care facilities in providing treatment to residents. So there were 27 aged care facilities that were eligible in the ACT, and we've had 24 responses to date. 23 of those 24 facilities had resident cases of COVID-19, 18 of which used Molnupiravir, so that's about 78%. In those 18 facilities, 355 residents had COVID-19, of which 188, about 53%, received Molnupiravir. And I just wanted to make a quick note of that. That was a lot higher than we were expecting, and we were really pleased with that result. 98% of those residents completed a full course. 2 out of the 188 residents who received Molnupiravir were hospitalised and recovered. 2 were hospitalised and passed away, and 2 passed away without being hospitalised. So the major barriers to use that we identified from this audit were that, first of all, residents who had COVID-19 were asymptomatic or had very mild symptoms. Tablets, well, specifically Molnupiravir, wasn't known to be crushable for patients with swallowing impairment. There were residents that required oxygen therapy, or the family or resident didn't consent or requested an alternate antiviral. And this provided opportunities to streamline our supply and provision of antivirals to aged care facilities. Lessons learnt, so I think primarily was really promoting awareness of the indications for treatment. So Molnupiravir and Paxlovid, they do include residents who are asymptomatic or have mild symptoms, and this is to prevent that or reduce the likelihood of progression to, I guess, the more severe outcomes such as hospitalisation. And it was a fantastic opportunity to promote awareness of the Don't Rush to Crush guide, which we'll flick to on the next slide, and really a role for pre-assessment of residents as well. So just quickly, I won't obviously read out this entire slide, but just to highlight that there are options for people that have enteral feeding tubes or swallowing difficulties with Molnupiravir. So capsules can be opened and the contents can be dispersed into water. And just quickly, Paxlovid is different, so the general advice is not to crush and just to chat to the pharmacist about alternative options. And I think that's all of it. Thank you very much.
Excellent. Just checking that everyone can hear me. Sally, thumbs up. Awesome. Thanks, everyone. My name's Gajan Perry. I'm one of the public health registrars here at ACT Health, and I'm going to talk briefly about some antiviral pre-assessment resources that we've put together to try and help usage in aged care facilities. So just a little bit of the context is, as Dr. Kuhl and Dr. Svoboda have mentioned, antivirals for COVID-19, and here we're including influenza, should be started as soon as possible to reduce severe illness and hospitalization. They have their best effect when started soon. In particular, Molnupiravir or Legebrio and Nirmatrelvir/Ritonavir Paxlovid should ideally be started within 5 days of symptom onset or positive test result, whichever comes first. And just to note, as Dr. Svoboda already outlined, a positive diagnosis is required for prescription of these medications. On the other hand, oseltamivir or Tamiflu, which is used for influenza, should ideally be started within 48 hours of symptom onset. Now, for the pre-assessment, considering which antivirals might be suitable for a particular resident and discussing them in advance can sort of help facilitate prompt prescription, especially in light of these limited timeframes. So the aim is to try and identify treatments that are appropriate for individual residents, and this is based on their personal wishes, their medical history and drug history, their clinical condition, and also any relevant advanced care directives. The pre-assessment process allows an option to discuss these with the residents and their families to inform them, but also identify their preferences and wishes. And then finally, having a pre-assessment process makes sure that you can check that processes are in place to facilitate the timely prescription, dispensing or delivery, and administration of antivirals. So hopefully you're all familiar with the aged care section of the COVID-19 website. I've just put the URL there, and I'm just going to guide you through where you can find some of these resources now. So if you go to that URL, it takes you to the main aged care website, which looks like this. This is the top half, and then it comes down to the bottom. And then just to highlight, this is a new tile, which is the advice on the use of antivirals in residential aged care facilities. Clicking on that will take you to this page. Now, this is the landing page that outlines a little bit about each medication. And if you scroll down, you get to a section here called Preparing for COVID-19 Treatments. Now, this section specifically mentions the 3 documents that we've prepared to try and be of use for you. So just highlighting the first one, a fact sheet for residents and their families. So this is a 1-page document that outlines the antivirals for COVID-19 and influenza. So Molnupiravir, Nirmatrelvir/Ritonavir or Paxlovid, and oseltamivir or Tamiflu. The form is designed for residents and their families, and it's meant to prompt them to speak with their healthcare providers about these medications to decide whether or not they're suitable. There are also some links there for risk factors for severe disease, product information, and updated eligibility criteria. So just a quick look at what the document looks like. It's pretty straightforward, something that can be printed out and provided to residents and their families. Looking at the next one is a fact sheet designed for clinicians and for the facilities. So this is a 2-page document that again outlines the COVID-19 and influenza antivirals in a little bit more detail this time. There's some considerations on dosages and timing, much like Dr. Svoboda mentioned, things like renal function and interactions. So there's links in that document to the updated eligibility criteria, the risk factors for severe disease, as well as the interaction checker that Dr. Svoboda showed you, the Liverpool one. Towards the bottom of the document, there are also links to other useful resources. So product information, health pathways, the latest RACGP guidelines for COVID-19, as well as the CDNA national guidance on outbreaks in aged care facilities. And that's what the document looks like. And again, this is something that hopefully can be printed out and distributed to whoever would like to have them. And the final document is a antiviral pre-assessment form. Now, I want to stress that this is not something that is required for prescription, dispensing, or administration of these medications. It's really designed as a tool to help facilitate conversations with residents and also a place to record relevant information. The idea is to try and make these as seamless and as easy as possible. And it can be filled out by any clinician, whether that's a resident's usual GP, their medical specialist or geriatrician, a nurse practitioner, or a pharmacist. So the idea is that this is a PDF that can be filled out electronically or printed and filled out manually and then placed in the resident's file. There's room to record treatment preferences for COVID-19 and influenza, and also places to record the appropriate dose for each antiviral based on the patient's renal function. So just a quick look at what the form looks like. So again, just a 2-pager. And the idea is that we'd be able to print it out and put it in the patient's notes. And that's it from me. Thank you.
Thank you. Thanks, Gaj and Emily. That was a useful summary. I'm just looking in the Q&A box, and I can see that some of the questions have already been answered if my mouse will let me scroll. The first question, I wonder if this is one that either Marianne or if you'd be comfortable talk to Marianne, which is the consideration about people who have COVID and influenza, noting that co-infection is still very uncommon, but is theoretically possible.
Yes. Well, we do have, you can hear me all right? Yeah. We do have people who have both, unfortunately, and the treatment is basically for both. So you may need to put them on both Tamiflu and one of the oral antivirals for COVID. So, and I guess all of the other treatments are still the same. I haven't, Anne-Marie might be able to give advice to this, but I haven't quite looked at the interaction between Tamiflu and ritonavir, which is one of the components of Paxlovid.
I'll look it up on the interaction checker now, Marianne. You keep talking.
Yeah, so just so that you all know, I know Anne-Marie alluded to this as well, but the interaction chart, the interaction app can be downloaded on your phone. I don't know how well you could see that, but it is called the COVID-19 eye chart if you're downloading it from the App Store, and it basically looks like a little green COVID virus. Can you see that, Sally? I know there's about 1 million.
Not
great.
super well, but
yeah, that little
yeah.
green thing. Anyway, so it's a little green box with a white COVID virus looking thing, and it's really useful not just for Molnupiravir, so Paxlovid, not just for Paxlovid, but also for other drug interactions that we might come across anyway in general. I wanted to just add a few little comments. Remember that that Paxlovid is far superior to Molnupiravir in terms of reducing complications such as, disease severity and hospitalization and mortality. So the effectiveness of Paxlovid is 70% effective, whereas it's 30% for Molnupiravir. So we do everything we can in hospital to make sure a person gets Paxlovid over Molnupiravir. One of the most common things that I've come across in hospital is Amlodipine is a known interaction, but remember that it's reduced effectiveness of amlodipine, which is actually quite useful in somebody who's got COVID, because you don't want them to have too much lowering of their blood pressure. So yes, you might have to monitor their blood pressure if you know, you're using amlodipine and Paxlovid together, but generally a person's blood pressure is going to be lower anyway when they have viral infection. The other one is statins. So some statins can interact. The natural thing for that is just to stop the statin, you know, so that you're not, that you don't have to worry. And then the issue about renal impairment, if you've got someone who's able to have a blood test to check their current renal function, and you know, your residential aged care facility is not in total chaos, it's probably a good idea to check their renal function while, you know, they're on Molnupiravir. And as soon as you get the renal function back and the EGFR is more than 30, then either give the lower dose of Paxlovid, which is 150/100, one tablet twice a day, which is the lower dose for people with GFR basically between 30 and 60. Or if their renal function turns out their GFR is more than 60, which is very unlikely in a residential aged care population, then you would give the full dose, which is 2 lots of the 150 and 1 of the 100 milligram twice daily. So hopefully the amlodipine, the statin and renal impairment won't be total contraindications to Paxlovid. It's interesting that you can't crush them, and I'll have to follow that up, because I think that's a big issue, isn't it, for residents? Yeah.
So Marianne, I just checked, there's no interaction with between Paxlovid and Tamiflu on the interaction checker, which is good. Yeah. I think just adding to those points that you said, yes, I agree that Paxlovid is ideal, but when you actually have your residents in aged care, practically speaking, it's very difficult to do some of those medication adjustments. And I think it's really difficult also to get a blood test done in somebody who is COVID positive in a facility. So I don't think it's really practical to, by the time you get the COVID test, they're going to be beyond their blood test, they're going to be beyond the day 5 for starting or changing to Paxlovid.
Thanks, Anne-Marie and Marianne. The next question there was a question about, and I wonder if, Marianne, you might be comfortable to talk to this. It was a question about nurse-initiated oxygen. The question was, is nurse-initiated oxygen considered a comfort care, or has to be discussed in resident aged care? I'm not completely clear on the question.
Yeah, I know what I think. I'm pretty sure I know what they mean. So nurse-initiated oxygen isn't just considered comfort care, so it is used as treatment as well. And should it be discussed? Probably, because if they're needing oxygen, it means that the person's illness is more in the severe category, or moderate to severe. So you would be having discussions at that point anyway with either the resident or the surrogate decision maker about, you know, what to do for the escalation of care. So I think purely because oxygen is a type of treatment in COVID, and that it indicates that a person's got a more severe disease, it is worth discussing it. And you know, unlike giving, say, Panadol for a bit of pain, where often we won't discuss it with the next of kin necessarily, I think oxygen definitely needs some discussion. And so, yeah, and it's not just comfort care. It can be useful for comfort care too, but it is a treatment also.
Thanks, Marianne. And I'm just scrolling down. I did note, and I might just talk, I can see that it's been answered, but there was a question about the supply that the Commonwealth Department of Health had provided, which was back in late February, of Molnupiravir. So our understanding from the Commonwealth is that that was a once-off pre-placement, so they're not going to resupply COVID-19 antivirals to aged care facilities. The idea of that, I think, was that they wanted to make sure that there was supply available prior to the PBS listing, and the expectation is that facilities will follow their established pathways with their community pharmacies moving forward. Noting that, of course, you can utilise supply that is available at facilities. And we're not, for the same reason, they weren't planning to provide a supply of Paxlovid because that had become available on the PBS. So that was my understanding with that question. I'm just looking back through.
Sally, there was a question that I saw about what happened to the RACF patients who didn't receive antivirals and how many of them died. I think that's a really interesting question.
Yeah, so we didn't actually look at that with the focus of this audit because it was very much just focused on the use of the Molnupiravir itself, and we didn't go through a line listing, line by line, of all patients who were cases in that time. And we were also very conscious that it was just a snapshot from between February and June that we were looking at. So it was a time where there was evolving advice about use of antivirals and access to them, and so we didn't kind of go through a line by line of all residents in that time. Yep. So I don't have that answer for you off the top of my head. Thanks, Anne-Marie. I'm just looking through. I think
I might, Sally, I might make
Yeah.
a reference to Julianne Samara's question about difficulties people are having accessing GPs, and I know Anne-Marie's response that it is within 5 days, so it often can wait till the Monday. But just in case, say, a person is at the day 4 of their symptoms and it's Saturday and you're having difficulty, remember during our hours, the GRACE team is around. So GRACE team often have access to the GP, possibly more, although I doubt it, more than the residential aged care facilities have, but they also have access to myself and a geriatrician on call. So, if it became really desperate, and I have done it once, we can write up the antiviral. It shouldn't have to be done after hours, like in the middle of the night. You can wait till the morning. But if you're really stuck, Grace team will be able to access a doctor to prescribe. And hopefully we don't need to do that very often. And Anne-Marie did mention CALMS as well. Is that right, Anne-Marie?
Yeah, so CALMS operates on the weekends, and they operate on normal hours in the weekends. So if, again, if you're in that situation where it really can't wait till Monday, then that's a good option as well. And the CALMS doctors certainly have been prescribing antivirals for people in the community.
I think the other issue happens is the prescribing of morphine and midazolam in end-of-life care. And that's been discussed internally between the Peace team and Grace teams, just, particularly on weekends. And if a GP can't be contacted or CALMS is not available for whatever reason, the Grace team can assist with writing up of end-of-life medication. But hopefully this is done preemptively too.
And I think, I guess just to add that that's one of the options. So like we said, the antiviral pre-assessment documentations are optional. We're not expecting everybody to necessarily have done that, but it could be a tool that some of those discussions can happen proactively. And then they're there to help the prescriber at the time review it and understand what discussions have already happened with that resident or their family. Are there any other, I can't see, I've been having trouble scrolling, but I can't see that there's any new questions that have come through on the Q&A.
Probably just one thing that I just was thinking of and to make a comment of is, so for example, with all the facilities we visit, we all have quite different processes for how the medications are obtained and how the prescription happens. So I think it's really important that everybody has a clear understanding of, do you just write it on the medication chart. So for some of the facilities I attend, I know that the medication chart acts as the prescription, but for other facilities, you actually need to provide a written prescription. So understanding those processes and making sure you know how to get that prescription to the pharmacy so that it's actually delivered in a timely way to the facility is really important. And I know sometimes I've had some difficulties with, when I'm communicating with the staff on site at the facility about, knowing whether or not you have the stock available on site of Molnupiravir, or whether or not you actually need a prescription. So just being really clear about those processes really helps the GP and the facility work better together.
Thanks, Anne-Marie. Any extra, I guess, final comments that either of you would like to make, noting that unusually for all of us, we're actually running on time?
I might just get a little bit of interaction from the audience. I noticed Kath Pollard, you're there, and Jill Dexter. How was your experience so far from a residential aged care perspective? Oh, if anybody wants to just make a...
Hi. So, look, most of us have been asymptomatic and very well. We do have 2 people on Molnupiravir at the moment who've just tested positive and are quite symptomatic. And we did use it on someone else recently. All very mild and didn't progress any further. But it just depends on, one of the gentlemen now has got, he's really a brittle diabetic and things. So he only tested positive yesterday. So we started it yesterday and we'll wait to see.
Can we unmute Jill Dexter? Jill, are you there?
Look, we've also had several residents with mild symptoms. They've all had the Molnupiravir and also the Pulmicort inhaler. All of them did exceptionally well. No one became very unwell. No one was transferred to hospital. We treated all residents within the 5 days. The average day was day 2, possibly day 3 at the latest. So we had really good outcomes.
We seem to also have someone from Goodwin. Can they be unmuted? Not sure which Goodwin. I have no unmute power.
Nell, are you able to assist with that?
Yeah, what's the name?
Yep.
Goodwin.
There's also Janet Nelson from Fred Ward Gardens. I think that's Janet from Fred Ward.
Oh, Anne-Marie, sorry, Janet here.
Hi, Janet.
I'm listening in the car, so I haven't got a camera thing. Well, you don't want to see my car anyway.
How'd you go at Fred Ward?
Yeah, I'm actually at Southern Cross Care now.
Oh, sorry.
No, that's all right. Just swapped over a few months ago, but we're doing quite well here. I just got one resident tested positive a couple of days ago, and he's just started on the, I can't say it, the Molnupiravir one.
Yeah, Molnupiravir.
That's Molnupiravir yesterday, but so far so good anyway. But it's been very helpful, this little chat session today. I've got quite a few good tips out of that, so thank you for that.
Great.
All right, see you.
And Goodwin, are they?
Yeah, they are on. I've requested. Yeah.
Yep.
Yeah, this is Trish from Goodwin. We've had success in all the antivirals that we've prescribed to all our residents, Goodwin-wide. Yeah, so far so good. We've been able to administer most antivirals within 12 hours, maximum 24 hours. So we've had a really good outcome in terms of getting medication to our residents.
It's great to hear that those processes are working well and that there doesn't seem to be any difficulty really with getting those prescriptions sorted. That's good news.
So can I just add to that? We had 13 vials delivered from the Commonwealth. So we haven't had to actually source it from our pharmacist yet, because we've only had 5 or 8 people who have used them. So we've still got 3 of the original, generous offer from the Commonwealth. So hopefully our pharmacists will be able to deliver if we need any further antivirals.
Thanks. And our understanding is that currently there aren't any supply issues that we're aware of in the community pharmacy sector in the ACT. So hopefully that should be available through your existing processes if you need it. Well, I might take that opportunity to thank our presenters today and also thank everybody for their time. I appreciate people making themselves available at relatively short notice and early in the morning, particularly on a fresh mornings that we're having at the moment. And yeah, thank you very much for your presentations, both Marianne and Anne-Marie, and also for those comments from people's experiences to date. And my understanding, sorry, I did notice there was a question about the presentation, presentations. My understanding is that this has been recorded and will be available on the CHN website along with the other webinars or presentations that they co-host with us. So thank you everybody for your time, and I hope that you have a nice rest of the day ahead of you.
Thank you, everyone.